by Dora for something that was on marijuanadoctors.com, a website I don't control. So I wanted to warn everybody about this, all right? Dora accused me of doing telemedicine, which we do not do and have never done and don't even have the capacity for. It's illegal to perform a medical marijuana evaluation by telemedicine, which I think everybody here knows. Marijuanadoctors.com, though, had taken and cut and pasted information out of the Medical Practices Act talking about telemedicine on their website. Well, the Medical Practices Act is separate from medical marijuana because medical marijuana was acted by a constitutional amendment rather than through the Medical Practices Act. So it's illegal to do a medical marijuana evaluation via telemedicine, but they had all the telemedicine info on marijuanadoctors.com, and Dora was saying, but it's right here on your website. I'm like, what website are you on? Marijuanadoctors.com. Put marijuanadoctors.com on the phone. They apologized profusely. They changed their website that day. They were like, she has no control over this content. I just wanted to warn you, though. And we were not the only Colorado doctor's office on marijuanadoctors.com. There were about 6 of them, all of whom I called and said, hey, this happened to me, beware. Right? So you too have now been warned. Be careful who is listing your information on your clinic or your practice on their website, because you can get in trouble for something you can't control.
Because they said that you were doing telemedicine.
They accused me of doing telemedicine.
No, I know what they accused you of. What did it say on this? Why did it? Where was the problem? I don't understand what the problem was.
Somebody had turned in marijuanadoctors.com to Dora as evidence that we were doing telemedicine because we're the first Colorado clinic listed in the Colorado section of marijuanadoctors.com. And because they had a telemedicine section, so here's our picture of our logo, and here's the information on getting a medical marijuana evaluation in Colorado, and telemedicine was one of the bullet points, and if you clicked on it, it had Medical Practices Act part and parcel on telemedicine, which doesn't apply to medical marijuana. I gave them language to put on marijuanadoctors.com. They changed it immediately. I told them, I will have 400, our mailing list for Colorado alone is like 450 people. I'm like, I will have 450 doctors refusing to work with you in about 24 hours if you don't change this. And they did. But it was pretty scary there for about 24 hours. And they did follow up with me. Dora did, the investigator called back and went to marijuanadoctors.com and saw that it had been changed. She also knew what my website was and saw that it wasn't listed there. But it was craziness. And I actually talked to someone in California who had a similar experience, though not over telemedicine, where they were investigated for information that was on a third-party website. So it's just kind of a big beware out there. So I'm waiting for Herve to figure out how to use Skype. Maybe he's done it. If not, we'll go with Dawn first. So most of our program tonight is talking about the IRB that we wish to have within our own group. And this is, I got let down by a volunteer. I met with a volunteer a year or so ago, and he said he would help me start an IRB. He said he registered something online, he gave me a number for that, he had done only part of the work, and he never completed it. And then he didn't show up for our Young Care Day, which was supposed to be the first thing we did under it, and as a result, I was the only person registered to work with human subjects, so I had to check everyone in, and that event did not go as planned in any way, shape, or form, and I apologize to everyone for that. But the bottom line of not having IRB approval on it is we cannot formally publish the results now. So all we can do is talk about it in among ourselves, and Dawn Cooper, who is our principal investigator on it, I gave some of the results last year, and Dawn, we're going to call into, and then he will give what he has on his end, which is a cognition test. Hey, Dawn.
Hey, how are you?
Good. Louis, can you come show me, tell him how to share his screen? So you're going to put your slides up and do a share. Louis is going to explain how to do that.
Okay, so what you do is there's this plus sign on the Skype screen. You should press it.
I'm calling in from my phone. So my computer, the Skype is not showing. Wanted to download something and it's not connecting. When you call, it doesn't show up on the computer. why.
Okay,
Okay.
we're gonna come back to you later and talk to Dr. Damas first, while you get that figured out. Because then once that's up, there's gonna be a little plus sign and you can share your screen and we can see your slides as you go.
Okay.
Okay. Sorry. Sorry, we will start with something else. So, we are currently in the Colorado legislative season. Hooray for the legislative season, right? And I have printed out at least the first pages, sometimes more, of the bills that apply to us or directly to us. Now, Priscilla Solis is here tonight, and she is the Deputy Director of Normal. I don't know, some of you, I posted it, where there was a Colorado Board of Health meeting on March 21st. And they sent out 35 pages of stuff. And the 35 pages, on page 34 was the only thing that was a problem for our group. Most of what it was, when we added PTSD as a qualifying condition, was done by legislative action, rather than through the normal channel of going through the medical board. And the reason is because the medical board turned down PTSD as a qualifying condition 12 solid years in a row, despite all the evidence and testimony that we gave them. So we went through this legislature instead. Many of you were involved in the Senate hearings on that, and I thank you profusely for that, because it's part of the reason that it went through was 8 members of our group showed up and did an excellent job testifying on behalf of adding PTSD as a qualifying condition. Now, when it was added as a chronic, not as a chronic, it was added as a disabling medical condition. Colorado Medical Marijuana Amendment is for chronic, debilitating conditions. So most of the 35 pages for the medical board was reconciling the word disabling with debilitating to make it match the Colorado Medical Marijuana Amendment. Now, part of the PTSD bill that we accepted simply to get it through was that as part of the PTSD medical marijuana recommendation, the doctor needed to review a previous diagnosis. For chronic debilitating conditions, no review of a previous diagnosis is necessary, meaning you can make the diagnosis for the condition that you think they should use medical marijuana for at the same visit that you're doing the medical marijuana recommendation. For PTSD, we went ahead to get it through and said, okay, will be a second doctor visit. So your first doctor visit for PTSD is where you get the diagnosis, then you take that diagnosis to your medical marijuana doctor for the recommendation. It's often a different doctor, or it can be the same doctor, but it's 2 visits because you must review that previous diagnosis. Now, on page 34 was where they were going to change the rules on medical marijuana to now require a review of records for a disabling condition. Unfortunately, the way they had worded it was a review of records for either a debilitating or disabling condition, which meant all of a sudden, the previous 8 conditions we've had for 17 years would now require 2 doctor visits because you would now have to review the previous diagnosis. Priscilla, thankfully, and Mary, who's downstairs at the table, I was in Israel then, you were Shalom that day actually, and they went to the Colorado Medical Board and said, look, if we make this language change, you're going to suddenly put an excessive burden on patients with the 8 qualifying conditions that we've already had for 18 years. What was the outcome of that? Sorry.
So what they said was that what they were doing is exactly what you had mentioned, is matching the language of the statute to what they have currently. And that was all that was adding and disabling condition. So wherever it said debilitating, they added and disabling so that we matched that statute. And it doesn't change anything on the patient's end. It doesn't change anything on the doctor's end. There's no additional paperwork or a change to the physician certification.
So it was not their intention to require a second doctor visit
Right.
like we have for PTSD?
Right.
And did they reword it so that it's not?
The board, well, the MED went up and kind of clarified after Mary and I testified, and they said that it wouldn't change any of the end user actions, but they were still going to keep the language and disabling because they were matching it to the statute that was in place.
But, okay, well,
But it's not gonna require, the med specified, and so did the Board of Health, that it's not gonna require additional, or it's not gonna cause that undue burden on the patient.
okay. Great.
How do they guarantee that?
We'll see how the wording comes out, and then I might complain again. Yeah, because I did send them a complaint and suggested new wording.
Yeah, and when we talked about that, they just basically said that it was because they were matching what was in the statute, and then the med verified that there was no additional paperwork required.
Okay, so it's,
But that doesn't make, if it's matching statute,
what they were, this was the one place where they had tried to match the chronic debilitating condition into disabling instead of just adding disabling to the chronic debilitating. Okay, I might follow up with Natalie Riggins on that one. But thank you so much for representing us and for
Yeah,
helping us with that. We really appreciate
It was
it.
my first time at the Board of Health, that was really interesting.
Oh, joy, yes. Did you learn a lot about Ebola preparedness and vaccines and hospital records keeping and sanitizing? Yeah. So, we have 3 bills and a stupidity that I printed out for us. The stupidity is crazy stupid. The stupidity is currently, fortunately, tabled. The stupidity is concerning the development of a marijuana tracking technology. This is our tax dollars at work. Governor Hickenlooper gave $1 million to CSU Pueblo 2 years ago to establish a cannabis research institute, and this bill requires the Cannabis Research Institute at Colorado State Pueblo to develop marijuana tracking technology, including an agent applied to a marijuana plant, marijuana product, industrial hemp, that would then be scanned by a device. In other words, they want to be Monsanto, and they want to insert either a gene or spray a chemical on all our marijuana to make sure that it was grown under the metric system. This is a terrible idea. This is poisoning us as, in effect, to try to get rid of gray market marijuana, which is not a threat to anyone. Fortunately, it has been tabled, but I wanted everyone to see how far things can go wrong. What
If people don't show up.
CSU is doing with our tax dollars. The goal of this, as stated here, is to sell it to law enforcement, period. Which I was talking to someone earlier about, am I working with universities? I have had difficulty working with universities. I seem to have a different agenda than they do because I don't care if we have anything to sell to law enforcement at the end of the day. I care about protecting our doctors and protecting our patients. So, yeah, if you ever see that one come to hearing, go and vote no, needless to say. Now, other ones that involve us here, there is one involving a school nurse to give medical marijuana at school. This one is a little bit difficult. I talked to Jenny Storms this morning and to Marcy, and they are members of the American Cannabis Nurses Association and also members of our group. And both of them are kind of opposed to this. And the reason they're opposed to this is this puts the burden on school nurses. And school nurses right now have an outrageous load of pupils. They'll typically have, you know, well over 1,000 pupils each, and they aren't at school every day. So it kind of falls into that weird area of what do you do on the day the nurse isn't at school when your child needs their seizure medicine. So I'm not sure how this one's going to shake out, and if you wish to go online and read it, you know, please do, and give me any comments you have, and if you think this is a good bill or a bad bill, because I'm up in the air on it, and I'd like your help and opinion on that one. Next up is one that comes back to the disabling condition versus the debilitating condition. And this is House Bill 1263 concerning adding conditions to the list of disabling medical conditions for medical marijuana use, including autism spectrum disorder and acute pain. I have no problem with adding autism spectrum disorder as a disabling medical condition, meaning you would have to review a previous doctor's diagnosis. Most people with autism spectrum disorders have had an extraordinary amount of medical care throughout their lives, or are having an extraordinary amount of care now because it is such a disabling condition. So I don't think it's a problem. If anyone, you know, thinks it is a problem to have 2 doctor visits required for that, let me know, because the hearing for this is on Thursday, and I will be there to represent us on this. The problem I have on this is adding acute pain. So the logic behind putting acute pain on here, when we already
Yep.
have
You
severe
got a
pain.
Skype call.
Oh, fantastic. Hold on a second, we might be going into. Herve, are you there? Hey, I can hear you, but I cannot see you.
For some reason,
Uh-huh.
I'm not. Hey, can you see me?
No? Oh, wants to show video. I need to accept video. There you are.
I don't see, I just see your profile picture, I don't see you.
That's okay, because we don't have our camera turned on? Oh, turn it on. Ta-da, now you can see us. All right. What you cannot see is the doctor's group here before you. Say hi to everyone, you can wave. And stay up on the screen, and we're going to switch to you. We were talking about a House bill, but now we're going to talk about the athletes in CBD. All right.
Did they have any slides?
He does not have slides. What we have is handouts that everyone should have. Let's see. You will need a handout. There we go. All right. And he needs a handout. Would you please run that up there? All right, Herve, so what everyone has in front of them is the short form. You're in a very dark place, aren't you?
Oh, I just stepped out of my house.
Okay, it's night where you are.
It is nice.
Oh, that sounds beautiful. Go for it. I don't know, we're trying to get audio connected now.
It was nighttime.
There, you look much better.
Where is he? Where is he? Where was that?
All right, so this is Dr. Herve Damas, and he is in Miami, Florida. Dr. Damas is the MD behind the Pro Athletes in CBD study, which I am hoping this group will act as our IRB now that we now have our IRB registered, and talk about using human subjects for this particular study, and hopefully give us an approval. Dr. Damas is a former NFL football player. He played for the Buffalo Bills, so he is very personally aware of how sports injuries can linger throughout your life.
Yes.
Yes. So why don't you tell us your story,
We
Herve?
can't yet, no. Can you guys, you probably guys probably can't hear this,
No.
right?
Yeah, okay.
Yeah,
Hold
we're gonna
on,
have to
we
fix
don't
the
have
audio.
audio hooked up yet. Okay, Louis is gonna hook your audio up, and I'm gonna tell him about the study, and then we'll put you back up. Because you're not on the big speakers yet. Okay. So let's talk about this study, and then we'll go back to the House bill on autism and acute pain. So the impetus for this study came from a guy named Patrick Carnes. Pat Carnes is a former athletic trainer for the Colorado Avalanche hockey team. In 2011, 4 hockey players took their lives in one terrible season. And all of them were the guys on the hockey team who were called the enforcers. And if any of you follow hockey, the enforcer is the guy who goes out there and beats up the other guys, you know, in the hockey ring in order to make up for any perceived slights or high sticking or icing or other problems that may have happened during the game. This is the way that Patrick sees the subconcussive hits, is what they found now, are more important in creating CTE than frank concussions. And these are the guys who took blows to the head frequently during games. Everyone knows that hockey is a very physical game and can be considered a collision sport because they're running into each other and throwing each other into the boards. It is a chiropractor's dream. I have a friend who used to be the team chiropractor for the Avalanche, and he said it was great. They were always at the joint. Anyway, he was very worried that he was going to have more of the players that he treats every day get into a situation where they would either, you know, commit suicide, or their quality of life would degrade to the point where, you know, they wouldn't have a quality of life. Well, Dr. Damas has seen similar things, needless to say, in professional football. So the idea was to do a pilot study with a small number of players using donated CBD. And the idea is to see if we can get a better quality of life using just CBD with retired professional athletes, and then present this to the NHL and the NFL as a full 2-year study and get actual funding for that we as a group can then conduct. So what we're using for markers in this study are a couple of different things. We're using standard neuropsychology tests. Have any of you heard of CNS vital signs? No? Have you used it all? No. CNS vital signs is a computer test that I have used in clinic helping car accident patients. David's not here. Yeah, CNS vital signs, it's a cognition test that you do on the computer that predicts closed head injuries, for example, or brain injuries.
You're fading in and out from the audio.
Okay, well, he's trying to put you on the big screen. Are we getting
We're
it?
on the big screen,
Oh.
however,
Audio's better now.
Audio's better now? Okay.
well, I know, I was just trying to figure out, like,
Next to you, I can hear him very well. You, at times, I lose.
That's because I was out in front of the audience. Now I'm in front of the computer with you, and that's fine.
I'm not even sure how to get.
We're not sure how to get the audio on. They also changed the AV system since we were last year.
It's complications.
It is complications. Careful, you're moving a whole desk. Anyway,
No, it really looked at
we're using donated product for this, and the donated product can come in whatever form that the CBD company wants to give us. We'll take anything from pure crystalline to a whole plant extract, as long as they have a certificate of analysis that shows that it is cleanly made, that it doesn't have pesticides in it, and that it is what it says it is as far as CBD content. Now, I met with Dr. Meshulam on this when I was in Israel 2 weeks ago. Pat Carnes had been out there last October and met with him about this study also. And when he talked to Pat Carnes, he'd given us some suggested dosing to try with these athletes. And the doses that Meshulam gave were 200 milligrams of CBD, 400 milligrams of CBD, and 800 milligrams of CBD. And I was like, oh my gosh, the cost on the product for 800 milligrams of CBD for the 60-day study is going to be outrageous. So I reshuffled it and said, okay, 400 milligrams would be the high end, and we would titrate the patient up to that. But first of all, we also don't want to start people out at 400 milligrams. They'll be asleep for a couple of days. Right. So we're now at 100 milligrams per day, 200 milligrams per day, and 400 milligrams per day. And when I talked to Meshulam about that, he said that 800 milligram number was only for immediately after the injury occurred. Right after the concussion, give someone a super high dose of CBD to see if you can prevent the concussion from causing further damage within the brain, was his idea on that. Now, for 400 milligrams, and for all of the doses, he wants to see it in divided doses. 100 milligrams would be 50 milligrams in the morning, 50 milligrams at night, and we'll grant all of the players up to this. We're not going to start them at those doses. And we'll work on that together on what that'll be. I'll write up a dosing protocol, so that will be included in the box that goes out to the patients. We're doing this with clinical supervision with Dr. Damas in Miami and with Pat Carnes here with Trust Grow Advocates, which is his athletic training recovery clinic here in Colorado. This also involves one other test. So we've got neuropsych tests including CNS vital signs. We've also got the Pittsburgh Sleep Quality Index, which is a simple, just one page to see how people are sleeping, because as you know, better sleep means less pain the next day. And then we have just a standard pain analysis. I don't remember which ones we're doing. But we do have a standard pain analysis score. All of those are computer-based tests that they'll do, and then they process really easily. The last one we have is something called a QEEG, and the Q stands for quick, and EEG is the thing where you put the colander on your head, and the wires come out, and it measures your brain waves across them. So the QEEG is the other study done on this. Now, I'll show you here in just a minute what that looks like. We did a sample test of the QEEG on someone who, the most competitive sport they play is Scrabble, and that person would be me. So, and as a competitive Scrabble player, I have not managed to injure my head yet, at least not externally. Anyway, we put the QEEG on me, and I will show you the slides for that in just a minute when we're done with Herve. And then we took what I consider a subclinical dose of CBD. I took 1 squirt of the Quicksilver nano-encapsulated CBD, and I took that one because we know the peak plasma time on it because it has pharmacokinetic data on it, and the peak plasma is 20 minutes. So 20 minutes later, we repeated the EEG test. I had 18% greater voltage across the frontal lobes with this microdose. I mean, it was basically 4 milligrams of CBD. But at peak plasma, an 18% increase in voltage. I had no loss in cognition when I ran through the cognition tests. And, you know, it was a good result. We'll see if we get those same types of results with people with these brain injuries, and that's what we're interested to find out. This QEEG study is frequently used in concussion protocols for football players. In fact, Colorado CU in Boulder has been using something like that to determine if people have had too many concussions in play. So those are the studies that we're doing. And now, do we have Herve?
They have a completely different speaker system for this, and I think it goes to this computer right here.
Oh, dang, which we can't get on, of course, because...
Because we don't have this. You get the name of password.
All right, well... Dang, why did they do this to us? They changed all of the equipment. You know, I pay a room rental fee here. They should give me a username and password. Anyway, I'll crank this up as far as I can, but I don't think that's going to do much. Oh well, talk to me. Let me see if I can just increase it from here.
Well, I imagine we're going to just...
All right.
We'll have to watch the video.
So we'll make a video of you, and you'll tell us your story, and I guess we're going to have to go from there. I'm really sorry.
That's all right, listen, I'm not even in my Sunday best, I'm in my, I was taking a walk, so,
We approve. All right, if there's questions from the group on this, I will
Can we
email.
move that computer into the center?
Let's try that.
Maybe we shut the door,
Yeah.
let out some noise.
Or if anybody...
I'm spinning you around. We're going to shut the door. Everyone wants to stand up and come
There
down.
will be a video of this, like, it's going to be your screen recording, so you will be able to hear everything clearly if you can't during this conference. You'll just have to be to when the video is out.
All right, talk to us, Herve, and see if we can hear you.
all right, can you all hear me?
Some of us.
All right, go ahead. How did you get into medicine?
Oh my God, you see, I have to warn you guys, I'm a bit loquacious, so Buffy just volunteered you guys for like an hour-long single week. So,
and telling them basically this is what I found out. And hey, so have you guys, can you hear me now? Did you hear anything before this? Hey, there you go. And I'm still a little bit of a space cadet. I'm getting high in a whole other way. So and so I remember him, telling me that, hey, you're really interested in this stuff. It's rare to find a player that's this interested in the human body. You should consider going to medicine. And I looked at him like, what? Are you crazy, man? I'm going to be playing football, fixing. And after that, I got into fitness. I became a fitness instructor, then a fitness manager at New York Sports Clubs. Then I got into the education or the science of exercise. And I became an instructor there, then faculty there. Then I went to school and got started working on my master's of science in physical education. Then I went on to the College of New Jersey, where I became the director of the wellness center there and a professor of health and exercise science at the college. 2002, my mother was diagnosed with breast cancer for the second time, and it was terrible. She suffered for 2 years, chemotherapy, she was on morphine, she was snowed out, drooling, she was in terrible pain, and I felt helpless. It was really painful because, you know, you can imagine, I am one of those, like any other kid, your mother is your hero. You know, I'm one of those guys, like, you know, I was on TV and I would say, "Hi, Mom," and that kind of thing. That was me. So I felt helpless, and that really bothered me. And in the last year of her life, and I wasn't aware of this, but she knew that she was dying, we had a conversation about what I was doing with my life. And she asked me if I was happy with what I was doing. And I said, well, you know, I'm at the college, I'm a professor, I got a good gig, and I can't complain. And she said, "Are you happy?" I said, "Well, I can't complain. Listen, you know, look at me. I'm making good money." And she goes, you still haven't answered the question, dude." And she says, "And the reason I'm asking you this is because you seem like you're going through the motions." And she said, "The only other time that I saw you really invigorated and with a passion about life was when you played football. Obviously, you can't play football anymore, but why don't you find something that you like to do?" And we started like hashing things out, and we got into medicine. And I said, "Are you crazy, Mom? I'm not gonna go back to school. You know, it's like, I'm 33 years old. Like, I'm not gonna do all that work." And she said to me, "That's funny because you never struck me as the kind of person who was afraid of hard work." And and that was it right there. She wound up passing later that year, and she wound up passing August of 2004. November 4th, I had moved to Miami, and I decided that I was going to go back to school. I packed all my things up, and in January of 2005, I was taking undergraduate classes at Florida International University to get my basic sciences so that I could qualify for medical school. And I wound up getting to medical school. It was a long journey. Either that was like I wound up going overseas for medical school. I was a non-traditional student. I was in my late 30s, wife and a kid by that point. And I thought I was going to go into orthopedic surgery. And so I was always pushing myself because I was a non-traditional student. I had to have higher board scores and be exceptional to kind of stand out, because there was kind of a stigma against that. And plus, I was a foreign medical student. Before you know it, I wound up in interventional radiology, wanting to be an interventional radiologist. And for those of you who don't know, like the hierarchy of medicine, the greater your specialty or subspecialty, the greater your stature and your salary, but the harder it is to get into. So your board scores, you have to be in the 90th, 95th percentile. And that was a lot of pressure. I put a lot of pressure on myself to do that. I started training like a maniac, and I started getting headaches. I had these terrible headaches that I was self-medicating, alternating with Tylenol and Advil. 800 milligrams of Tylenol, and 2-3 hours later I would take my Advil, and then 4 hours later I would take my Tylenol, and then I had really bad insomnia. And I would take Benadryl for the insomnia, which would make me groggy the next morning, which I hated. And then I developed anxiety, which was true. This was like, what the hell is going on with me? I'm a pretty cool dude. I've never had those. All of a sudden, like, all these things started happening. And next thing you know, I'm on Xanax, which I hated as well. I couldn't take it. And then the next thing you know, I wind up with something called exertional compartment syndrome. I was overtraining as part of my compensation, my way of coping with everything that was going on. And exertional compartment syndrome requires a surgery called fasciotomy. Basically, you just slice your leg open and slice open the fascia, which wraps around the muscle so that you can get circulation to your leg. If not, you'll lose the leg because the circulation gets cut off. They prescribed me Percocets and Oxycontin. I knew from college that I could not take these things, but I'm in terrible pain. So I take a Percocet. I have an out-of-body experience. I hate it, so I'm relegated to suffering. Right? Headaches, insomnia, and I'm in pain, and I have to study for medical school to get into interventional radiology because I want to be the best, because I want to be an astronaut of medicine. And then I'm like, I can't take this. I take the Oxy, and I felt like I was going to die. My girlfriend at the time said to me, why don't you smoke a joint and relax? And I fought her. Man, you know, I was an athlete, I was smart, I would do drugs, you know, I was a football star, I was, you know, that stuff is bad, I'm a doctor now, do you know, I give them up 4 months or 5 months of bouncing off the walls, and I just gave in. I just like, okay, I'll try it. And I smoked, I swear to God, that's what happened. It was just like, there's nothing else for me to do. I cannot take this anymore. I'm willing to do anything. I smoked. I did like the whole thing. I found some dude in medical school, and I was like, hey dude, do you know somebody to get me some stuff? And and like, yeah, I got a number, and I called the guy. Never bought marijuana in my life before, so I'm like, oh man, I hope I don't get arrested. I ruined my career doing this stuff. You know, I went to this guy's house, and it's like some shady thing, and I smoked, man, and I felt like my world opened up, and I was just like, oh my God, I cannot believe that this has been out here all this time. I can't believe, what the hell have I been, what? I was like, are you kidding me? I thought this was just like the potheads in school, the zeros did this thing. And I remember smoking all throughout the rest of medical school, and I decided then that if I ever had a chance to get into the medical marijuana field as a physician, that's what I would do. So fast forward 5, 6 years, I'm here in Florida at my radiology residency last year, and I get an email from the Department of Health in Florida that the legislation has been approved, the regulations are in effect, you can now sign up as a medical marijuana prescriber. This was October 14th. October 17th, I started my LLC. November 9th, the end of October, I was talking to my supervisors at the hospital about getting out of my program. November 9th, I went to my NFL Players Association retired players meeting because I knew in my heart, and I said, if I'm the one that supposedly made it, if I'm the guy that's got it all together, that I found a lot of success in other things after football, but here I am, anxiety, headaches, insomnia, mood swings, like bouts of rage, literally like, you know, just uncontrollable, like, So if I'm the one that's supposed to be well-adjusted and doing well in society, I can only imagine what the rest of these guys are doing, what's happening. So I said, this is gonna be the first group of guys that I speak to. I went to that meeting, and I spoke to them, I told them my story, and I said, if any of you guys are going through the same thing, call me. You don't have to worry about anything, it's confidential, I'm one of you. The next morning, I got a phone call. The following morning, I got a phone call from someone else in Tampa. That was in November. I saw my first patient in a hotel lobby. I didn't have an office. I saw my first patient in a hotel lobby at the gym that I trained at, Don Shula's hotel in Miami Lakes. That's where I trained at as a personal trainer, so I can get into medical school, take my classes to get into medical school. My second patient I saw in the bar of a restaurant during NFL players. Yep, the third patient I saw in the Starbucks. And that's how, and guys had just been calling each other and saying, there is one of us that's a physician, that's a medical marijuana doctor. Call him because I know what you're going to. And that's how it started. I just started getting phone calls from one player to another player, and then it was their wives, and then their family, and then before you know it, in December, I called my good friend Jay Coda, and I said, hey man, this is what I'm doing. And he says, don't reinvent the wheel. Come here. I have to introduce you to a good friend of mine. Her name is Muffy. And she is going to get you started and help you get your wellness center off the ground. And we met, and I told her my story, and she says, oh my God, I have this study that I want to do. And I said, oh my God, I want to be a part of this study. And that's the short story. That's the short of it. And in 4 short months, I guess from December to now, I have not only become a part of this, and because of my credentials and my background, I'm able to use that to bring more authenticity or more kind of panache to this, and I'm happy to do that. I'm able to recruit players easily. They trust me. They confide in me. I've been doing speaking engagements. I'm on the board of Athletes for Care. I'm on the board of directors for Athletes for Care now. I am opening my wellness center next month. We are doing the largest 420 event in Miami now. We're the only ones doing an above ground 420 event. And it's going to be, it's something new in Florida. And I have the star power, I have athletes coming, I have other physicians and people and that's the short of it. And my wellness center is basically a holistic healing center. And it's just everything that I've done in my life that's gotten me to this point. From physical activity to the wellness center that I ran in the College of New Jersey to what I taught there. Everything that I taught and I believed in, and and what happened with my mother. This is it. This is what I do. I love what I do. And I'm so glad that I'm not an interventional radiologist because I hated radiating people. I hated radiating people. I hated radiating myself. I hated prescribing opioids. I hated everything I did for that job. And now I love what I do every day. So I'm on board, man. This is my thing. So that's who I am. And I'm willing to put my name, my services, my energy, my blood, sweat, whatever I gotta do to make this happen. Not only that, I'm the only person that's got connections with the NFLPA and the NFL. Senior level connections. I'm the only one that's already spoken to them and said, I'm gonna bring you the data. When you're ready for us to sit at the table, I'm the one that's gonna get us in the door.
So what types of injuries are you seeing in the players that you're talking to? What types of quality of life issues are you seeing?
Oh my God, this is heartbreaking stuff because I actually go to their homes. So I'll give you a story. I have one player who told me, he said, you know what? I go through these dark periods of time. There was one time when my wife left and went on a cruise for a week. And I had to nail my windows shut and pull the blinds and curtains because I was afraid I was going to go outside and harm somebody. I didn't know who to call. I was afraid. I had another player call me one time and say, I have to talk to you, I have to talk to you, I have to talk to you. I say, all right, I'll talk to you. No, I have to talk to you. I saw him in person. I went to see him in person. We met at a public place and he couldn't speak. The following morning, he called me, I have to talk to you. I said, all right, come see me. We meet, and he tells me that he's ready to kill somebody. He's ready to harm somebody. Right. We can't put this on the air. This is all private. So if this comes out, he'll know it's him. So I want to tell you right now, right? And he tells me, like, I'm going to kill this guy, and I'm going to do it because of these reasons. And we spoke for 2.5 hours. And after I made sure that he wasn't going to harm anyone, after I acknowledged his pain and his feelings, and he knew that, hey, I'm not going to let you leave if I gave him a vape cartridge. I gave him a vape cartridge with, what did I give him? I might have given him East Coast Alien, I think, or something like that I gotten from Jay, which was one of my favorites. And I said, go home, smoke this, because he hadn't gotten his card yet. Smoke this and tell me how you feel. And I checked on him and I said, how do you feel? And he gave me 2 thumbs up and a smiley face. And the following morning I texted him and said, how are you feeling now? Because I feel great. I said, if you ever feel like that, you did the right thing. Make sure that you call me. And I followed up with him every day. I had another player who told me he's 35 years old, he's been diagnosed with cognitive impairment, had to close down his business because he was forgetting his employees' names, 35 years old, forgetting his employees' names, forgetting to pay the bills, forgetting all types of things, fits of rage. A lot of these guys can't even handle, if they don't have like a wife with them or some partner with them, can't handle their bills. Now these are the worst ones. Cannot handle their daily living, cannot remember to do things, cannot do the calculations, cannot balance their lives. I've had guys, and these are the bad examples. People who are 43 years old, I lose my way home. Other ones, I had guys tell me, I'll tell you the truth, Doc, there are times when I sit and there's something in the back of my head that says, "Rah," and I know it's coming, and I try to control it, and sometimes I just have to let it out, and it's been bad. So usually what I do is I drink, or I do other things, and the drinking makes it worse. Now, my wife has told me that, and this is a common thing, you're drinking too much. And I have to tell them, if the person next to you is telling you that something is wrong, something is wrong. She's not telling this to you. She's not telling you these things because she wants to bust your chops or be evil, B-I-T-C-H. She's telling you these things because you're not aware of it. Then you can't, and this is the example that I tell them all the time. When you got hurt physically, if you broke your leg, what would tell you that you have a broken leg? Your brain. Your brain would say, holy crap, there's something wrong with your leg. What's going to tell you if your brain is broken? What's going to tell you that there's something wrong with your brain? There's nothing to tell you that. Somebody else has to tell you that, right? And so I've seen those things. I've seen people with debilitating. I've got a patient who's on his second ankle replacement, a hip replacement, and 2 knee reconstructions. Cannot walk. I've got testimonials from these guys. I've got testimonials when I give them CBD products. I tell them all the time, listen, realistically, the high is good for you, and we'll talk about how the THC affects your mood and some of the medicinal properties of the THC. But CBD, that's your daily beater. That's the guy that's helping you out that you're not aware of.
So let's talk real quick about these people because they're already using other things for their problems. One of the things about this study is we're doing this as a supplement to their existing treatments, not a replacement for them. So right now, we've only excluded a very tiny group of people. And that tiny group of people is people who are insulin-dependent diabetics, because the CBD is so good at lowering your blood sugar, and we don't have people who can monitor their blood sugar at these other locations. So insulin-dependent diabetics we're keeping out of the study. But if you've got anyone else that you think we should be excluding, it's all in the long form there of who we're excluding. We're also, obviously under the age of 18, they have to weigh over 120 pounds, I think it is.
Major depressive disorder.
Don't you think we could help the major depressive disorder, or do you
Because
want to exclude that?
with the dosing that we're giving them, when they get down deep, like when they're down deep, that's only going to keep them down there. Like if we're giving them 100, 200 milligrams a day, we're talking about someone whose mood is already depressed. Yeah, and then we're giving you something that's not going to elevate your mood. It's just going to add to that. So. And so I'd be careful with that because these guys get deep. I mean, it is, if I can be honest, at times it's exhausting. I can tell you, I'm in their homes and I'm seeing these discarded commodities, for lack of a better word. These human beings who were once these proud and glorious conquerors and caregivers and they recognize that. That's the thing. They all know. Like, hey, no one values me anymore. Like this thing that used to give me purpose and identity, and that was who I was. I'm no longer this. But not only that, there's something wrong with my head, and I know there is, and I don't know what to do about it. But not only that, I can't walk, or I can't do this. So all these things add to them, and they tell me these things. And that breaks my heart.
Can I ask a question?
So, yes, Paul.
Can you hear me? Doctor?
Yeah.
Yeah, what about these dosing and the drug-drug interactions of the dosing, of the drugs that they're taking, and the ones that may elevate levels, and cytochrome 450, and so on and so forth?
So, so that's standard stuff. We have the data on those things, anything that so the easiest way to think about it is anything that's hepatically metabolized, that's cleared through your liver, then you have to start considering that. But that information is already, like, we're not breaking new ground on that, so we already know those things. But what you guys will be surprised at is that these guys are already taking themselves off their medications. They already hate them. They hate the side effects. They don't like being put in, and they have an inherent distrust of a lot of doctors because of what's happened to them with the team doctors. And so once once they go somewhere and they get a prescription for something, the first thing that goes through their mind is, I don't trust that guy. I don't want to take this. So a lot of these guys they've already stopped taking their meds. If it's anything psychotropic or anything like that, they're like, I don't want to do it. I don't want it. I'll take my chances. I'm already self-medicating with marijuana. That's what I hear. And I said, well, are you going there? And he goes, I go to these places and I hear the same crap. Oh, this or that. And then, they're caught up in the NFL web of, we promise that we'll take care of you, but access to that is limited, right? We'll promise that we're going to take care of, look, there's $700 million in the concussion protocol. But you're not going to get that money for 10 years, and you're going to jump through 30 hoops, and we're going to do this, and we're going to find ways. And they're really distrustful of anything that's affiliated with any, major institution or organization. And there's a reason why. Look at what happened to them. Yeah. So they come in, they tell me, hey, this is what I was prescribed. They'll show me the pills. Say, look at all these pills. I'm not taking any of these things. I refuse to take it. I'm not taking it. I've been waiting for you, Doc. That's what I'm telling you.
Do you think we should adjust the dose, even though Meshulam recommended that 400 milligram one? Do you think we should take that one off and have it be 50 milligrams, 100 milligrams, and 200 milligrams instead? Do you think that's more practical? Especially because we found that original dosage was, he thought that these were people with current injuries, not, injuries.
So one of the things I would say is that from and I haven't done it, this is my anecdotal observations, is that daily supplementation, so you need 25, 50 milligrams. People, they've been reporting to me, I get text messages, hey doc, thank you, I'm sleeping better. There's one patient, I can tell you his name because he's agreed for me. His name is Rusty Russell. He's the one with the 2 ankle replacements in the hip and the knee. He called me and said, well, one of the other players said, you need to go see Rusty. He's not doing well. He's in Orlando. I drove from Miami to Orlando 3.5 hours to go see Rusty. And I got to his house and he's there. He's like, Dad, I can't take it. I cannot take, they gave me the Percocets and I can't do it. And I said, what's your pain right now? He goes, I'm in a 5 out of 10. I'm at 5 out of 10 constantly. I said, you're living? He goes, yeah, I have to do that. He goes, but at midnight, and if anyone who's ever had major orthopedic surgery, you get these things called night pains. If anybody's had night pains, you know what I'm talking about. He goes, at midnight, I can't take it. That's when I have to do something, and it messes me up for the halfway through the following day, but I just can't take it. So I gave him some sublingual drops. I gave him a tincture bottle of what I have. Hey, take this. Let me know how you feel in an hour. I asked him 45 minutes, hey, Rusty, how's your pain? He turned to me and said, what pain?
And what kind of dose was that you gave him on that?
I gave him 50 milligrams.
So let's do that then. Let's cut this to 50 milligrams.
So I'm gonna, you said morning and night.
The Meshulam recommended we cut the doses in half. So
well, the only reason I'm not saying morning and night, I'm saying throughout the day. If it's 100 milligrams, 25 milligrams
4 times a day.
4 times a day, and we go up to 200, we'll do the math, 400.
Great. So
but I found that works best for. I'm dealing with a lot of the same issues with people.
Right.
Who's speaking now?
My name is I have a dispensary in Boulder, and I've been dealing with a lot of people up at CU, a lot of ex-athletes that are dealing with this. Some are actually ex-alcoholics, because exactly what you said.
Yeah.
And,
Self-medicating.
right, and they're all doing it. You know,
Yep.
they're all doing it.
So what I found is, the 25 milligrams daily has stabilized the mood. It has stabilized the mood swings. It has eliminated the headaches. And then the 50, around 50 or so at night, and I'm talking about dudes, and you've seen this, I'm talking about dudes, so I haven't done any LFTs or any panels on it. So I'm being a little bit of a shaman here too, right? So I'm not doing blood work and I'm not checking liver clearance or anything like that. I'm being a shaman and going off of medical history and body happiness. And I'm looking and saying, based upon what, everything that I've done in my life, I can kind of eyeball you and say, you're good at this, and this is what you need to do daily. That's what I've basically been doing. So I've been doing some people, some of my players, I've told them, you need a 25 every day, and then at night, for your insomnia, you're gonna go with 50. And that's worked. And then I get these text messages saying, you're a life changer, doc. I'm so glad you came into life. Like I get these crazy, like these random text messages, like, hey man, I just want to let you know I had a great weekend this weekend. I'm glad.
Oh, that's great.
Yeah, it's incredible stuff. I wish I could share you. So Rusty has sent me, and I said, hey Rusty, he sends me pictures of himself smiling. It's a crazy. So that's what. So when you told me what Rashula wanted to do, remember the first thing I said. Where did he get these numbers from?
Well, that's what I said, and the answer was it was from studies on people who had just been injured, and he's trying to prevent the injury from spreading. So I think we're perfectly fine to adjust these downward, and I like the idea of breaking them up into doses throughout the day instead of just doing morning and night like he suggested, especially because, like with type 2 diabetes, every 8 hours is where we get the best results, and if we stray from that schedule, their blood sugar starts to, rise and fall again.
Now that you mentioned that, two instances, all right, and this is what happens. I've had orthostatic hypotension, all right? All right, so I had one guy who's on hydrochlorothiazide for blood pressure, and he takes it intermittently, right? So his blood pressure is so he self-doses, he checks that. So he's complained of dizziness once. And I had another person say, well, that's something that we know as well.
Yes,
so
that cannabis lowers blood pressure and raises heart rate temporarily. We definitely know that. Yep.
Yeah, so we know that. So that's one of the interactions that we would be concerned about. I like the idea of dosing throughout the day and the 50 prior to bedtime for the insomnia. Because as we said, quality of sleep, I mean, that's when you do all your healing. I mean, that's when it happens, right? So if you're not sleeping, then we're kind of, hurting ourselves there.
Do we want to allow any self-dosing by the patients, or do we want to have this?
No.
Nope, okay. How about anyone in the group here? What do you think about that? Same thing, no? Nope, okay, no self-dosing by the patient.
All right,
But, so
here's the other thing I would say with that. So I don't know how many of you guys have been on these. If you probably have been on journal clubs. If you've probably been at these conferences where we try to destroy every piece of research that comes out. I don't know if you've been part of those, right? So we would meet regularly. Every week we have something called journal club, and we have a piece of research, and our job is to eviscerate. Find every single thing that we can find wrong with it to say that this is a piece of crap. And so knowing that this is what I know this is what people are going to want to do to this, we want to be as tight as possible. So any kind of like, hey, you know what, you're putting out data, but some of your patients kind of dosed their own and did their own thing. How do you know? I want to be able to say, no, they did not. They did not. This is our study. Our study's already underpowered. So we're going to have that thing. It's a preliminary study, but it's underpowered.
great, here, you've got a question. Go ahead.
have them bring back their empty containers at every 2-week visit, and be really firm on that, and then you can tell.
That is a great idea, yes,
Really-
because we've got to check in every 2 weeks, and if they bring back their empty containers, we'll know exactly how much they took. That is a great idea.
Not necessarily.
Well, okay, that's true, because what if they took it all at once?
Yeah.
Yeah.
So what,
It's true. Are they
now,
like-
here's the great idea. This is a great idea. This is a wonderful thing. We're in this wonderful age of technology. We can set up dosing emails or texts that go out at regular intervals saying, this is your time, this is your time, this is your time. They get
Yeah.
the reminder, and that's it. It comes out
absolutely can.
automatically. This is time for you to take your medicine. And that way, we know that they're being reminded, right? We know that we've done everything that we can to make sure that they adhere to our protocol, the dosing intervals, the amount, the whole thing. I mean, we're not giving to them, so we're trusting them, but the more control we have, the better we.
You got it. More questions?
So, I'm just thinking, you mentioned that a lot of these guys were alcoholics. Do we need to do baseline LFTs to see if they have any damage to worry about problems with CBD or anything else?
You know, the only place where we've seen issues with CBD interfering with liver function is at super high doses. It's from Maureen Leahy's study on cannabis and Parkinson's disease, and her IRB, you know, like wouldn't let her patients drive on CBD alone, and she had all these weird restrictions. And they were giving doses in the 2,500 milligrams per day and up range, and that's where they saw altered liver function. We're not giving anywhere near that dose, so I don't think we're going to have liver function interactions from an alcoholism perspective. There's a couple other drugs, and I've got a list that I'm sure Herve does too, that we can go over that we know, and most of them are, like he said, blood pressure meds that are known to have a problem. And you had?
This is more of a comment. We're working with a cannabis industry partner for our veteran cannabis study, and they have a Bluetooth vape pen that measures milligram dosages. So if that's something that you
We're
guys can
allowing a variety of medicines here, not just, in fact, I don't think we have any inhaled ones right now. We've got swallowed liquid, we've got sublingual under the tongues, we've got a liposomal spray taken under the tongue, swallowed capsules, and a nasal spray at this point in time. We don't have any inhaled medicines at this point, and I mean, I guess we could if it fit the criteria. So that's a possibility that we could add on. One of the questions, though, on these different methods, the liposomal spray has 8 times greater uptake than a traditional sublingual medicine. They've done the pharmacokinetic studies on that. So I have 2 liposomal sublingual providers for this, and they're asking that they give the patients 1/4 of the dose. And I am totally okay with that after looking at the pharmacokinetics, which I can also send to you. And I'll put those up online for everyone so you can see the pharmacokinetics on liposomals also. Once you do that nanoencapsulation, the blood absorption is just so much more rapid. And that's what I used when we did the test on me to see what the increase in brain voltage would be, was the liposomal, because we knew what peak plasma was. Paul?
What kind of CBD products are you using or using?
That's, yep. It's hemp derived, CO2 extracted, and it's less than 0.8. I'm in Florida, so we have to be less than 0.8% of THC. So it's considered full, quote unquote, full spectrum because we do have some of the other, but it's so small that we're allowed to be legal.
Do you have terpenes? Are you having terpenes in it as well?
Minor amounts.
So it's not full spectrum, really?
So, exactly. So what I'm saying is that because we're in Florida, we're limited. We cannot, as a physician, I cannot dispense that. So I have to.
Only state.
No, but I understand that. But do you have a specific brand that you like?
Do I have a, no, I have my own. So we source our products from Hammer Enterprises out in Colorado. They are hemp farmers, and their strain is YP. This year they farmed YP 1, 3, and 5. That was their strain, so that's our stuff. I love it. You know, it works for me. And their analytics, and then Jay checked it out for me. This is one from Mark Buffy. I took their products and I took it to Florida.
Fantastic.
Jay, check this stuff out. These guys are telling me all this stuff, I don't believe them. He's like, you don't know, check this out. So yeah, I like my stuff, but everybody, you know, if you, I mean, we're not like, you're like, I'm not, this is not rocket science, right, for me.
Yeah.
I'm not, right, so.
Well, and
Yeah,
because the study is using donated product, like I said, we're taking anyone who can submit a valid certificate of analysis who wants to donate product so that we can include as many players as possible. I mean, it's not just Herve's stuff that's going to be used. We're hoping to use David's trill pills as well.
And those are full spectrum.
Yep.
They'll show turkey.
So how much THC is gonna be in your product, in those less than one?
Yeah,
It's a hemp base, yeah.
it's a hemp-based product.
Yeah,
Mhm.
yeah, so, yeah, I mean, yeah, pretty much.
Okay, we got to move on, so we're going to ask any more questions on this.
Is
Go
there
ahead.
going to be issues with tolerance buildup?
That's a good question, and we are going to do a ramp-up period on the patients, and everyone will get, we're working on those documents now. I've got the basic questionnaires done for inclusion and exclusion, the ones that they'll fill out. I've got samples of the CNS vital signs, the Pittsburgh quality of sleep study, and the pain index for everybody that will all be online for everyone to review. And then once we finish with, my goal was to get this done today and approved so that I can then send the blast out to my CBD vendors and see what I get back. I've got like 3 or 4 certificates and analysis back now. We've got CW Hemp, we've got Elixinol out of Boulder, I've got Quicksilver Scientific, I've got Authentic Hemp out of Carbondale, we've got one out of Oregon company, Select Hemp, I think. We've got David's product, the Trill Pills, and we've got Haley's Hope right now. And
I
Dr.
think-
Damas is also.
Yeah, and I think Marvin Washington, who's with Isodiol, we hate Isodiol.
We have Isodiol, yes, and I've talked to Isodiol too. I've been talking to Scott at Isodiol. Isodiol is a controversial one, and the reason Isodiol is controversial, they're backed by Philip Morris, the cigarette maker, and there was a lawsuit that settled in September where their scientists wound up admitting in court that the numbers that they had given on their CBD products were not real, that they had faked their scientific results.
Oh my God, there's dishonest tobacco company.
Well, it's not the tobacco company, it's if you can't trust the certificate of analysis, if the scientist from the testing lab is saying, yeah, we were told to up those numbers or not get paid. Right, that's where things get difficult, and that's public record in a lawsuit, so hopefully
We can say
they are doing
Why?
better now. I would assume after the lawsuit that they are no longer using that testing company and hopefully have good results now. So,
nice.
Do you see any application for topicals in this study?
what do you think, Herve?
What did she say? I didn't hear that.
She said, do you see applications for topicals in this study? I'm not sure. It's a quality of life study, but with the WAVI brain scan that we're doing, the QEEG, I'm just not sure we're going to get results that will show on a QEEG. So I think we're going to leave topicals out at this point in time because we don't want to say, CBD didn't work because the topical didn't work, but all the rest of them had results.
I think Muffy, like I mentioned earlier, we need to be as strict and as tight as possible. Anything that we start doing kind of creative opens us up to more scrutiny and like, hey, this is the data, but these guys, they were doing all kinds of stuff.
Exactly. I'm still worried about the nasal spray method of absorption here because I just don't have any data on pharmacokinetics for nasal sprays at this point. I don't know if it's going to absorb the same as a sublingual.
She's got it.
You got it? Fantastic. We'll keep the nasal spray.
Hey, there we go.
To suggest for that, because you had asked if we could think of any other exclusion criteria.
Yes.
You might just add something kind of general, like the clinician can make the determination?
Oh,
That
yes,
is- yeah.
that, I gave you the full 20-page one.
Oh.
That is in there, and there's the
Okay.
standard Red Cross, you know, if they've got
Yeah.
an active communicable disease, if their vital signs are way off whack, the clinician can say, no, I'm sorry. We're following the standard Red Cross
Yeah.
inclusion, exclusion.
Or
too.
even if he determines that they can't follow study directions or something, you know, like that. Or
Unable to follow directions?
Or would
So-
not be compliant,
They'll all be
something like that.
So you're talking about the
Or
patients
just
with
make it real
dementia and
general,
cognitive
so in
impairment?
case something comes
So are
up.
they concerned about the players that have dementia and cognitive
Yes,
impairment?
exactly.
Those type- So what happens is, as you get evaluated by your neurologist or whomever, your neuropsychologist who says, who diagnoses the level of cognitive impairment, if you are at a point where that you cannot do these things, for example, administer your own medication, then you have to require a caregiver. So if there was a patient that had been diagnosed with this, I can't diagnose, this is not within my scope of practice, so I cannot diagnose with someone with cognitive impairment. Someone has to have someone whose specialty who is qualified to do that. If this person does have that, and it's to the point where they are not able to medicate or take care of themselves, activities that they living, they would have a care provider. And then that person would be the one to administer medication just like anything else.
Okay, so if they have the cognitive impairment and they have a caregiver, they can be okay. It'll be a clinician determination on that one.
Yeah.
Yeah, that sounds
Yeah.
good.
We'll have to send the consent forms.
Oh, no, we've got consent forms. Actually, I would love to have your help on some of these forms. That would be great.
Where are the site locations for this?
The site well, we started out
What did
with.
she say?
She's
I didn't hear
asking
it.
what the site locations are for this. We had started out with 9 site locations, which are the QEEG site locations. But at this point in time, we're talking about just having Colorado and Miami for the site locations so that we can follow the patients more closely. We have had so many patients who wish to participate saying, just send me the stuff, I'm in Austin, Texas, things like that, where I don't even have the EEG available, that we're talking about just keeping it Colorado and Florida to start with, and then branching out from there so that we have that control on it. And that's one of the things that Pat and I have been discussing. And Pat is going to fly down to Florida to meet with you personally and do the EEG on you too, so that you've got the idea of how that goes.
You might not want to.
Hey, see if you can beat my score on the cognition test.
I might come back and say, hey, are we sure we want this?
No, it's so you can see how it's administered and what the results look like is why. So you're going to get the personal demonstration.
Yeah, I would love it.
Yeah, but that's what we're talking about now is doing it more limited than we had originally expected. Originally, we had so many people come. I mean, I had calls from all over the place. I had emails from all over the place saying, I have to be on this study. I'm really suffering. And it's too out of control if we don't have a clinician in the area, is what we decided. So, yeah, so I'm glad you agree with me on that, because I hate leaving people out. But the goal of this is to get a full 2-year study, funded by either the NFL or NHL or a combination of the two, where we can really do a better, more controlled study. Personally, I love a great uncontrolled population. I mean, the idea that antidepressants are only tested on people that don't drink, I think is absurd, because most depressed people drink, right? So you're not getting a clear view of how well they really work. So I like uncontrolled populations, but I think to get the data that we need, the next one we're going to have to control a little better, which is fine. This is just a pilot study.
Yeah, exactly,
Yep.
and I agree with all of that.
Yep. Okay, anything else for Herve? All right, let's thank
That's
you for talking to us.
I'm looking at Muffy's beautiful face all the time. I haven't seen the room.
I don't have the right cord for that, but they're here, I assure you. Next time we'll have
A laugh track.
a room cam. That's it. There we go. And I'm going to play you the Frank Zappa song about you. Okay. We'll talk to you later.
All right.
Thanks so much. Bye-bye.
Bye.
So, okay. Questions, comments, more things? Like I said, yes, I would love to have your help, a researcher, on writing my questionnaires and things like that for the patients. I'm so excited about this study. One of the first things Herve did was he sent an email to what he calls his NFL Legends group. So he calls me up one day, he's like, you know who Jim Kelly is, right? I'm like, yes, I do. Didn't he also play for the Buffalo Bills? And he's like, yes, he did. He's a Hall of Famer, and he's excited about this study. Unfortunately, he was just diagnosed with cancer recently for the second time and won't be participating with us this month. But that's the sort of caliber of athletes that we've got, interested in participating, which I think is
So do you
fantastic.
need more?
Yes, we will need more. Now that we're through this, I'm going to write up the results of this meeting. I'm going to give it to the person, Dr. Russo, who helped me register the IRB, and make sure that she approves. And based on that, and then I'll post everything else on the website, you'll have a chance to look it over again, and I'll have a comment period. But we'll be able to start recruiting patients then, now that we've had this meeting and had this discussion. And if you do have changes, after you've read through, and the full 20-page document, I only have a few copies of here, but it is on the website, or I can email it to you. And if you want to comment on that, please contact me anytime. I'm looking for feedback on this. So, great. Let's see if we can get Don now to go over just a few things from last. Okay, Don has to go because he wanted to go first, but he didn't have Skype loaded on his computer, so we had Herve go first, and now Don has to put his kids through. Okay, sorry, next time. That's okay, we'll get him here in person next time, because he lives in Boulder, just his kids are sick. So he can, make it here, anyway. Let's look at, though, while we're all here, at that WAVI test and what it shows. So this is the control report of me, and this was back in December. So what we have here is session 1 and session 2. So session 1 was initially when I came in, and session 2 is after taking the microdose of the CBD. They're on the P300, they call it, the frontal voltage there. You can see the time delay increase, but the big one was down here. Dun, 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 dun. Oh, my time on, so trail making is the cognitive test that you do while you have the colander on your head. Except for this one's a plastic one with little things. Anyway, so it was 43 seconds on the cognitive test. The first time through after the CBD, I was 42 seconds. On the second cognitive test, which is more difficult, I had 45 seconds both times, so there was never any difference in that. So it did not affect my cognition. But there is the difference in voltage between session 1 and session 2. You can see it in the orange wave there, I was shocked by this. I did not expect that small of a dose to produce anything like this. And Don Cooper, who's, like I said, our on the Cannabis Clinicians Colorado board as a researcher, can totally explain this to you scientifically. I cannot. He will teach me how to do that. But he was like, I'll tell you exactly why that's happening with CBD and exactly what's going on there. So the other way to look at it is, and like I said, I didn't have a difference. The purple one is session 1, the red one is session 2. So I had a drop in delay between the electrodes. So I play Scrabble and a lot of video games, and my reaction time is like supposedly better than a 20-year-old's somehow, which I think is crazy, but they're playing football and I'm not, and I think that's a difference there. Because I test out as a normal 50-year-old on this one, but once again I'm better than a 20-year-old somehow on the second one, which is just nuts.
Yeah, you.
Video games are good for you. So here's the difference between number 1 and number 2. The top one is number 1 of the connections made. These are the additional connections made after the CBD. I mean, it really did improve voltage and improve voltage connections between the different points. Those are all the points on the colander where it was actually stuck onto my head. This test does mess up your hair. You've been warned. And I did put that in the information for patients, in the 20-page thing, is the patients will be notified this will mess up their hair. It puts goo in your hair. But we're really excited to see how this plays out over the course of the study, where we can see the connections hopefully improving as they continue on the treatment. So what it is, it's 60 days of CBD, and then there's another 30-day period where we're going to be crunching data, and then they'll see the clinician one last time at the 90-day mark to see if there were any lingering positive effects or negative effects after they stop the CBD. So we've got that going on too for just one last hurrah on the brain scan. So, and there's the alpha beta, there's just the raw data. I like it better in picture form for this. All right, so that's it on our studies. Let's go back now to talking about autism and acute pain. So the autism, like I say, I have no idea, I have no problem with adding autism as a disabling condition, which requires the doctor to review a previous diagnosis at the time of writing the medical marijuana recommendation, therefore requiring 2 doctor visits. I just don't think that's a problem for people with autism spectrum disorder because of the extraordinary amount of medical care they typically have. I do have a problem with the acute pain problem. I don't think that the reason that acute pain is being considered as a disabling condition is detailed well enough in this bill the way it's written, and I will be testifying on this on Thursday. Right now we have severe pain as a qualifying condition. Anyone who's a clinician here knows that severe pain is defined as a 7 or above on a 1 to 10 Wong-Baker pain scale, which is a standard for assessing pain in the medical world. As long as the patient can say they're a 7 or above, or say that they have symptoms, if they're not numbers people. There's also symptoms that relate to that. And a 7 or above is where it's interfering with your thoughts, interfering with your activities of daily life. As long as the patient's willing to say this is interfering with my activities of daily life, we can do the recommendation under severe pain. Now, what is in the severe pain statute with medical marijuana is those are for chronic debilitating conditions. So chronic conditions are generally defined as ones that have gone on for 90 days or more. So the idea of adding acute pain here was to add pain that is recent and not yet chronic. But I think this is a bad way to do it because it causes confusion then between whether the pain is acute and whether the pain is severe. We already cover severe pain that's chronic. The idea behind this was someone who has had an auto accident or a surgery last week. You wouldn't have to wait 90 days for it to be, quote, chronic before you wrote that recommendation. And the goal of this is to reduce opioid use and reduce the number of opiate prescriptions that are written for acute pain, meaning the pain that's right now. I think this is confusing personally, and I think in most cases, if the physician believes that the condition will become chronic, you know, if you've been in an auto accident and your leg is now pitted, the chances of that type of severe fracture becoming chronic pain are quite high. So I don't see why the doctor could not make a recommendation for chronic severe pain when he knows that that pain is going to become chronic in the future, just because it only happened 2 weeks ago. Maybe I'm splitting hairs on that. Does anyone see a problem with that? But when I testify on this, I'm going to ask that the acute pain be taken off of this because I think it muddies the waters. Yes?
I spoke with our sponsor today, and there will be an amendment to the acute pain portion of it.
Okay, fantastic.
So we'll talk more about it afterwards, but it is being addressed.
Excellent.
I know that there's been some, I'm Michelle Walker.
Yes.
My son has autism, and I am basically at the Capitol every day lobbying on this bill. I don't want anyone to think that acute pain was just kind of an afterthought for this bill, whereas in fact, this was the bread and butter of our bill, and autism was kind of thrown in at the end. But it's kind of switched. It seems that autism is kind of leading it right now, where autism is really holding this bill together. Muffy has made some concerns, she's made her concerns apparent and aware to me, so I'm speaking with our sponsors so we can address it, and we don't want to throw anyone under the bus.
Fantastic.
Patients need to be taken care of. So it will be addressed, and we'll talk more about it.
I'm still worried that the medical board is going to go with the original language instead of the language I proposed, which could have the unintended consequence of requiring a second doctor visit for all conditions. And, you know, I'm glad Priscilla was there and presented it as succinctly as she did, but I'm still worried that they're not going to think it's a big deal and that it will wind up being a big deal. So we'll see what happens. But that's my concern on this, is the second doctor visit requirement.
We will definitely talk about it after this, and I want to work with you to make sure that we have the proper language.
Great.
The pain part is not so much my specialty, but it's my bill, it's my baby, so we're going to work on it, and we're going to try to make it as successful as possible.
I am 100% for adding autism. Is anyone here against adding autism, or are we all for it? Okay, yeah, we're all for it, that's what I thought.
If anyone has any questions, please reach out to me, and if anyone feels led to come and testify on Thursday, it's going to be at the Capitol in the basement. We're scheduled for 1:30, but let's be real, we are the last bill on schedule, it's going to be 4 or 5. We need medical professionals there that are in support of this and can explain why cannabis doesn't break our brains. Yes, this is still a real issue that we're having to combat. So if anyone would be interested, I would be indebted to you, and I'd be very thankful for anyone that would be interested in testifying on Thursday.
Fantastic, I'll put out an email to the group also about the date and time for that.
I appreciate it.
Like I said, we did great last year on having people show up for PTSD, so let's show up for autism this year too. Yep. Any more comments on this? Anyone think I'm off track? Think we're okay?
Do you feel like doctors feel comfortable as it is when they see somebody that's been in an accident prescribing cannabis because it's not chronic yet? I mean, because I know I had a tooth pulled and the doctor wrote me a Vicodin and I was like, I don't need Vicodin, and he didn't discuss cannabis. So, I mean, do you feel like that's going to take us away from that?
I know a lot of doctors who would not write you a medical marijuana recommendation for your tooth pull because it is not chronic. You know, if you had months of dental pain before getting it pulled, they would write you from that. Or if you had TMJ or resulting, chronic.
Well, that's what I'm asking about the acute, is so if it was because now it's acute, would they consider writing it because it's now been passed in the House that allows it?
Possibly, but the burden, you would then have to take a previous diagnosis to the medical marijuana doctor now, because disabling conditions require that review of a previous diagnosis, and debilitating conditions do not. Right. And we're trying to keep it that way. And I know it's confusing. It just has to do with the fact that the medical board rejected PTSD 12 times. That's how we got to this. So, anyone else?